Let's disclose this lecture. This presentation is offered by the Department of Emergency Medicine in coordination with the New Jersey Institute for Successful Aging. And this lecture is supported by an educational grant from Renal's Foundation. Before proceeding with the lecture, I have to tell you about the learning objectives of this lecture. It includes to identify risk factors for adverse drug reactions, to understand pharmacokinetics and pharmacodynamics of the drug, to know how to use renal function parameters for determining the safe dose for a drug, to understand drug-drug interaction, which affect pharmacokinetics and pharmacodynamics, and to understand drug-disease interaction. Okay, this year we put a couple of questions just at the beginning of the lecture, as a pre-test cases. Okay. Mr. A.B. is a 70-year-old white male who was brought to the emergency room with history of confusion, lethargy, and no urine output for 1 to 2 days. On examination, he was found to have dry mouth, lower abdominal pain, and distended urinary bladder. After insertion of a Foley catheter, patient had a urine output of 1800 cc. Patient had no problem before with his urination. He had no fever, no shortness of breath, and no meningeal signs. On laboratory evaluation, CBC, basic metabolic pattern, and urine analysis was within normal range. He has diabetes, for which he takes metformin and glipizide, hypercholesterolemia, for which he takes Zocor, and he takes also amitriptyline for his lower extremity neuropathic pain. Recently, he developed some stomach discomfort, and on the advice of his wife, he started taking cimetidine, which is Tegamed, basically. I have one question. Which of the following is responsible for the current problem in this patient? Okay, you can give you a response. So just remember which of these answers or option you chose. There is another case, pre-test case. Mr. KK this is not Kalashnikov, okay, KK something else, is an 80-year-old frail male who has been sent to the emergency room from a nursing home with history of confusion, nausea, vomiting, and palpitation. His condition was stable in the nursing home until 3 to 4 days ago, when he developed cough, for which he was started on erythromycin 500 milligram PUBID for 7 days. He has past medical history of CAD, CHF hypertension, and ambulatory dysfunction. He is on these medications currently, and this is the lab work done in the emergency room, and this is the EKG. Probably you know what type of problem he has in his EKG and what lab abnormalities he has. You may give all of the following except slowly infused calcium gluconate, give patient digibind, give glucose with insulin, give 15 grams of kioxalate. Okay, now I would like to go. You may choose your answer. Okay, give patient digibind. So remember which answer you chose, okay? Again, next question, okay? This is after fixing the urgent problem and stabilizing the patient, what would be the most appropriate step to take? Again, what answer you chose? Okay, let's proceed now. Just remember which answer you choose. Let me start, this section of the segment of the lecture with a quotation from Paracelsus. He was a German physician living in the early part of the 16th century. He was born in Switzerland and died in Austria. He says, all substances are poison. There is none which is not a poison. The right dose differentiate a poison. So it means the drug you administer to your patient, sometime it can be a poison, okay? Only the dose make the difference. Okay, we talked about drug. What is drug? Before going into pharmacokinetics and pharmacokinetics of drug, we should know the definition of the drug. According to WHO, drug is a substance that when administered into the body of a living organism will turn normal body function at the cellular and molecular level. That's what I add. So what is adverse drug reaction? Any noxious, unintended, and undesired effect of a drug which occurs at a dose used in human for prophylaxis, diagnosis, or therapy. So that's the definition of the drug, and this is the definition of adverse drug reaction. We have problem with managing our elderly patient because of many reasons. One is aging population is increasing. Baby boomers basically entered, they're 65 years of age, I think in the year of 2011. And in a couple of decades, our elderly population will double. Presence of comorbidities in our elderly patient. With age, the number of comorbidities increases. Inappropriate use of medications. And if your patient comes to you and you don't prescribe a medication or a pill for him or her, they don't like it. That's a rule, and every physician knows about that. Underuse of certain medication. We don't use some medication properly. For example, lisinopril, warfarin, in this type of. Unreported medication. Sometimes we don't know about medication. And sometimes they call me in the middle of night and say, hey, we don't know, well, pharmacy is closed, no family available to provide us with a list of medication. We are stuck. And unreported advanced drug reactions by patient. Patients don't know. Sometimes they think side effect of a medication is just part of the problem they have. There is a study, it was more kind of a survey type of study conducted in the continental US, including Washington, D.C. It was conducted on 2,600 patients, of which around 600 was elderly people. They asked them if they had took any medication, any drug, prescription drug, in the previous 1 week. Preceding 1 week, and this was their answer, basically. They are non-hospitalized adults, okay? They are not hospitalized. You see, with age, the number of medication they take increases. You see here, with age, any medication used in the preceding 1 week increases among those who are 60 years of age or older. The same thing with women. Of course, women take more medication as compared with their, with men. And this is not just about prescription. If we see, there is also use of herbal or supplements. There was a study conducted in Dallas, I think, in Texas, on 1,000 volunteers. They basically reported intake of herbal alone, vitamins, and herbal with vitamins. And you see here, it varies with ethnic groups. Whites takes more, Hispanics follows whites, and then blacks. These are the three important, these are those important supplements: garlics, ginkgo biloba, I can't say it, saw palmetto, and St. John's wort. Glucosamine and chondroitin sulfate for arthritis, and calcium, multivitamins, and vitamin D, E, and C. These are the medication they take usually. Okay, we talked about the herbal supplements. We have to talk about their effects and their side effects. Ginkgo it's taken to improve memory. Basically, it improves blood supply to the brain. And the anticipated side effect of this is increased bleeding if patient is taking aspirin or warfarin. Sopalmet 2 is another medication which is supplement or herbal medication which is used for urinary problem. It may interfere with some hormonal therapy. The same thing with Jones wort. It's a mood stabilizer. It helps with sleep and anxiety, but it interacts with other medication like sedatives, verapamil, warfarin, and serotonin, basically SSRI. Garlic is used. A lot of people like garlic because they believe it decreases cholesterol. Sometimes it interacts. Some studies shows interaction with some drugs in animals, but we don't know in human yet. I start with a case. This is a real case, you know. AB is a 75-year-old white female weighing 110 pounds who visited the emergency room of the hospital with history of fall, which was associated with no loss of consciousness. The fall occurred this morning when she was trying to get out of bed. She has been feeling dizzy for some time and has throbbing headache, mostly during the day. She reports multiple visits to the primary care physician in the last 3 to 4 months for chest pain, but with no help from the medication prescribed. She further says, I still have chest pain, but on top of it, now I have headache, dizziness, and swelling of leg swelling also. Patient has chronic medical problem of coronary heart disease, hypertension, depression, hyperlipidemia, and non-specific abdominal and joint pain. These are the medication this patient is on. Plavix, Florinef, Toprol-XL, Zocor, aspirin, Zoloft, Lasix, potassium, Amdor, Lyrica, Naratriptan, basically used for migraine, and Tylenol. Okay, based on the history, and again a question, based on the history and symptomatology, which of the following drug has triggered the whole cascade of symptoms? Okay, I'll start with, you see A, who says A, who says B, who says C, and who says D? Okay, Amdor, that's good. That's a correct answer. You see here, this patient, chest pain, started in Amdor, caused orthostatic hypotension, headache. For headache, they started this medication. For orthostatic hypotension, they started Florinef. Florinef caused leg edema. Lasix was given. Lasix again caused decrease in high blood pressure. Patient is also Lyrica. The whole cascade will continue and continue. Okay. If you kind of decide to remove some of these discontinue some of these medication, probably these medication in red would be the appropriate medication to stop. Okay. Advanced drug reaction occurs everywhere, in every healthcare provision setting, outpatient, hospital, emergency room, and nursing homes. Poor transitional care may contribute to adverse drug reaction. The other thing is failure to recognize adverse drug reaction. Sometimes we get confused, you know, this disease-related symptoms with, we get confused adverse drug reaction with disease-related symptoms. The same thing with disease progression and new diagnosis. Failure to recognize optimal treatment is another thing. Patient problems are not optimally treated, so they come with persistent symptoms. And for that, we start new medication. I give you one example. Of course, lisinopril is a good medication for heart failure, but the patient is not started on any lisinopril, and she or he comes again to the emergency room with shortness of breath, and we put her on Lasix every time. Of course, that causes dehydration and other thing. If we kind of optimize the treatment for heart failure, probably there is no need for putting her on Lasix again and again. Polypharmacy is again another problem. According to a study published in the Journal of American Geriatric Society, these are, 6 common reasons in some way related to adverse drug reaction for which patient is admitted to the visits emergency room and gets admitted to the hospital. Neuropsychological disorder, this is something we call change in mental status. And hypotension, acute renal failure, electrolyte abnormalities like hypo or hyperglycemia, impairment of heart automatism, for example, arrhythmia and other conduction, heart block and other conduction problem. Increased anticholinergic effect, again, patient is coming with confusion because of anticholinergic medication she or he takes for his bladder, for example, or her bladder. These are the most common medications or group of medications which are responsible for adverse drug reaction. Diuretics, warfarin, NSAIDs, chemotherapy, cardiotonic agents, anti-epileptic agents, and antibiotics. Of course, we receive a good number of patients from nursing home, and most of them come with history of dehydration. And we kind of review the medication. We see this patient has been on 40 or 50 or 40 or 80 milligram of Lasix once or twice a day. That's understandable. The other thing is warfarin. Warfarin is a very typical drug. It interferes with everything. I mean, the moment you start a patient on antibiotics or other medication, please check INR. And if some patient is on anticoagulation and he or she is on other medication, it's really difficult to adjust the dose of Coumadin. The only way you can adjust the dose is by ordering INR. That's, I think, the only thing we can. Chemotherapy, of course, that causes a lot of problem like anemia, pancytopenia, weakness and other things. Cardiotonic agents, for example, digoxin. You have a lot of patients with ditch toxicity coming to the hospital. Anti-epileptic agents, again, they interfere with heart conduction, they can cause tremor, confusion, and other things. Antibiotics, of course, they interfere with normal flora, the function of normal flora of the gut. They cause C. diff. C. diff is very common now, and C. diff is basically very dangerous in elderly patient. You lose your patient to C. diff very easily. Why we have all these side effects from drugs? For many reasons. One thing is age-related. Of course, when a person ages, its physiology or her physiology changes. There is a decrease in muscle mass. There is a decrease in metabolism of the drug. Decrease in volume of distribution and all these things. Presence of other comorbidities, CHF, peptic ulcer disease, diabetes mellitus, seizure, dementia, electrolytes abnormality. When your patient has CHF, you have to be careful with the type of medication you give. For example, those sodium-containing medication is not good. Some of those medication you use for treatment of diabetes, like Avandia, that's not good. And some medication which interferes basically with nerve conduction, some antiarrhythmic medication. Peptic ulcer disease, of course, NSAID is a very good example. Dementia, anticholinergic medication, diabetes mellitus, long-acting medication, seizure, some type of antibiotics, for example, quinolones, Levaquin. And electrolyte abnormalities, most of these patients have electrolyte abnormality. You have to be very careful. I give you, because we have a question here, I give you example of ditch toxicity. Of course, anytime your potassium is high, you give calcium to stabilize heart conduction. But when you have ditch toxicity, you cannot give calcium because calcium increases, you know. When you give calcium, calcium increases serum calcium. It kind of help, you know, digoxin with increasing calcium level inside the cell. So that's one contraindication. I mentioned that one because we had a question. Multiple care provider. Of course, we have subspecialties that make our job easier, but sometimes we have communicating with them. You know, we can read their mind, you know. And every time a patient visits a physician, a new prescription is given. That adds to the problem also. Co-administered drugs. If you give 2 or 3 medications at the same time, they interact. So that interaction affects pharmacokinetics and pharmacodynamics of the drug. This is a graph. I got some information, some idea from a site, and then I just you know, put it this way. If you see here, this is time, of course, this is young persons, and this is what? Young adult, and this is what? Old and elderly person. If you see, this is concentration of the brain, this is concentration in the serum. That because of good blood-brain barrier, there is a lot of drug that can go to the brain. So the distances, the gap is big here, it's wider. In case of elderly patient, because blood-brain barrier is kind of affected, or, you know, porous a little bit, so that gap narrows. And the other thing you see here, side effect threshold, this is in case of young adult, and this is in case of an elderly person, it decreases. So it gives you some idea how drug pharmacodynamics is basically different in case of elderly person and a young person. Okay, we talked about all those. Now let's talk about a little bit basic pharmacology of the drugs. When we talk about basic pharmacology of the drugs, pharmacokinetics and pharmacodynamics come to our mind. Pharmacokinetic is basically what the body does to the drug, and pharmacodynamic is what the drug does to the body. We have absorption, first pass effect, distribution, metabolism, elimination, and clearance. Absorption, of course, if you give drug parenterally, it goes directly into circulation and get to the site where it exerts its effect. And most of the cases, you use lower doses. But if you give some medication to your patient orally, the drug goes through certain processes like dissolution, ionization, and all type of things, you know. So then they get absorbed into the body. First pass effective, basically, this is the first barrier drug has to pass through, go through. And this is a wall of metabolism. Anytime drug get absorbed from the gut, they go through some process of metabolism in the gut and liver. That's called first pass effect. And that metabolism, that process, that's kind of decrease in elderly people. So it means more drug get to the circulation. Distribution, again, we talked about decreased change in the volume of some compartment and decreased volume of distribution. in elderly. If you have decreased volume of distribution, it means you have higher concentration of blood in your circulation. Metabolism, again, affected in elderly. Elimination and clearance. Drugs are eliminated from the body either by metabolism or by clearance renally. Okay, that's the same thing. What about pharmacodynamics? Pharmacodynamics is therapeutic effect, side effects, and adverse drug reaction. So this is a diagram basically. You see here, drug is taken orally. It's absorbed into portal vein, goes to the liver. This is the metabolism side on the wall of the gut and the liver. This is basically makes your first pass effect. Then it gets into circulation. From circulation, it goes to extravascular, extracellular space, then to other compartments of the body. And it gets excreted here in the kidney. Again, okay, we talked about metabolism. We have to a pathway which basically is composed of phase 1 and phase 2. It's more historical, but it's not necessary that a drug goes first through first phase and then go through second phase. Sometimes basically a drug goes through first phase, then goes second phase, and then go through first phase. But the purpose of this pathway or this metabolic pathway is to make all those non-hydrophilic drugs more hydrophilic, because our excretory, all these medications are excreted through the kidney renally, and kidney has a mechanism which is kind of water-based, So if we have more hydrophilic drugs, they get excreted through the kidney easily without going through these things. But if we have more non-hydrophilic, then it's kind of those drugs have to go through these pathways. So there are some components of phase 1: oxidation, reduction, demethylation, hydrolysis, and these are some components of phase 2. We talked about metabolism. Cytochrome P450 is a set of enzymes. It's huge, basically. There are a lot of subfamilies there. They are responsible for metabolism of any medication that get into the body. And I told you, if they are hydrophilic, they can get easily excreted. But if they are not, so they have to go through those things. These medications are their substrates, you see, all these things. Amitriptyline, all these things. And these are the inhibitors, and they are inducers. Sometimes these substrates may act as a kind of blocker by substituting that site, by occupying that site. And sometimes they may act as inducer also, because there is more need for metabolizing those drugs. Just keep in mind this amitriptyline, omeprazole, and that's basically warfarin, you see. Pharmacodynamics is all about drug target interaction and action or effect. So it depends on the drug concentration times time at a given site, okay? And also it depends on receptors and single transduction. Just interaction of drug with the receptor is not everything. Signal transduction is very important also. And the other thing is counter-regulatory mechanism or process. For example, if you take a beta blocker, which decreases your heart rate, your blood pressure drops, yeah? So counter-regulatory mechanism is that mechanism of the body which causes constriction of your blood vessels, okay? Normally it works, but in elderly people who are on multiple medication for hypertension, those mechanisms are all blocked. There are some facts about receptors, property, and pathway of actions. There is beta adrenal receptors downregulation, decreased dopaminergic receptors in the brain, increased inhibitory effect of warfarin, increased sensitivity to anticholinergic effect of drugs, increased CNS effect of benzodiazepines, opioids, and psychotropic medication. And there is another thing, decrease in hemostatic mechanism with aging. I told you about that constriction of blood vessels. This phenomena is called hemostenosis, I think. Okay, now let's go. It's the same, it's one of those things, okay, cases. This guy who was, if you remember, admitted to the emergency room because he was found to have dry mouth, lower abdominal pain in distended urinary bladder. After insertion of a Foley catheter, he had 1,800 cc of urine output. Laboratory workup was within normal range. These are the medication, metformin, amitriptyline, and what? Zocor, all this type of thing. If you remember, I told you just pay attention to this amitriptyline and this Tagamet, which is cimetidine. Okay. Which of the following is responsible for the current problem in this patient? Okay, you go ahead. This is the same question. I want to see if you learned something or not. Again, the same thing, yeah? And not very much different from the previous response. Okay. Renal clearance. We talked about metabolism, now we talk about clearance. Mechanism involved for renal clearance is glomerular filtration and tubular excretion. Glomerular filtration depends on kidney function, blood flow. Tubular excretion basically depends on net tubular excretion, which is excretion minus reabsorption. I told you about renal blood flow. And unbound fraction of the drug get easily through the glomeruli and get into the nephrons. So molecular size also plays some role. And again, urine pH. These are the factors which affect renal clearance. Okay, we talked about renal function and renal clearance. These are the way, this formula we calculate renal function, or GFR, which is, one is Cockcroft-Gault formula, which is simple, and it is good for screening. It's good for normal functioning kidney. The other one is this MDRD, modification of diet in renal disease. This is the name of that study. So it's very hard to calculate. I use computer and calculate basically this GFR using this formula, but it's very hard to calculate. But luckily, when you order basic metabolic panel, they use this formula and GFR comes, okay, along with that, with other findings. So this is good also. This is better than the first one, but it is good for patients who have kind of stable kidney function, stable kidney function in patients who have kidney disease, and also in diabetic patients, and also in African American. In this one, 24-hour urine collection, it is very simple. You use urine sample for 24 hours. If your math is good, sometimes I make a joke, I say it is 5th grade math, you know. You see how much creatinine has been created, is present in 24-hour urine. Then using that one, comparing with renal creatinine, serum creatinine, you can calculate how much of serum basically cleared, from creatinine in 24 hours. It's very easy. This 1440 is basically 60 multiplied by 24 hours. Okay, tubular excretion, it's non-specific and maybe saturated because there is a mechanism involved, a structure involved, it's also called get saturated. It is not for a particular molecule or drug, but it is for a particular class of, what type of molecule. Excrete ions and protein-bind molecules. Some of these are some of the acidic molecules like penicillin, furosemide, probenecid, this type of thing get excreted through acid, those channels which are responsible for excretion of acid. If you see here, we use sometimes probenecid to compete with penicillin to kind of decrease excretion of penicillin, so get a good level of penicillin in the body. The other thing, basic, those channels which are responsible for excretion of bases, these things. You see, these are procanamide, dopamine, and other thing. And there is another mechanism which is called P-glycoprotein transport. It transfers these things, erythromycin, digoxin. So if digoxin and erythromycin is given together, okay, they kind of interact, And user of this mechanism is rifampin in St. John's wort. Okay, let's talk a little bit about reabsorption. You see here, reabsorption is all lipid-soluble molecules get reabsorbed because the wall of the lumen is lipid, yeah? And it is passive, you see? Filtrate is coming down here, water is getting absorbed, high concentration here, and because of high concentration, more of the molecules are getting reabsorbed. But think here, pH helps. For example, because if you make a molecule more acidic, there is less chance for that to get reabsorbed. If you make a molecule more basic, there is less chance to get reabsorbed from the lumen. Probably you know sometimes you make urine more acidified or make it more alkaline to get rid of some drugs, I want to tell you something, okay? It's very, of course, there are two ways to get rid of drugs from the body. One is metabolism, and the other excretion. Of course, absorption, when it comes to absorption, there is no significant change with age. There may be some changes. You have to be aware. There may be something you have to keep in mind, like drug interaction or the interaction with food and other things. Metabolism, phase 1 and phase 2. Some changes with age with phase 1, but there is no significant change with phase 2. And the other thing is, you don't know, it's very unpredictable. So you have limited access to that area, basically. And it varies with the individual. Renal clearance is very important. Please, anytime you prescribe any medication, you have something in hand. Based on that, you can make a calculation of the dose. Pay attention to that, please. Okay? Case 3. Mr. KK is an 80-year-old frail male who was brought to the emergency room of the hospital. Again, this is the same question which was asked, in the early part of this lecture. He was stable, basically, and later on, recently he had some cough for which he was given an erythromycin for cough. And because of that, patient developed confusion, palpitation. This is basically the what? The medication this patient is taking, this is the lab work, and this is the EKG, yeah? You want to, enough? Okay, you may give all of the following except, again, I'm asking the same thing. You may click, okay? Slowly infuse, except, this is except, okay? Slowly infuse calcium gluconate, give patient digibine, give glucose with insulin, give 15 grams of caxylene. Okay, that's a good thing. Something, some improvement. Okay, after assessing the patient, evaluating the medication and fixing the urgent problem, what would be the most appropriate step to take? Again, I secure answer to this question. Okay. Okay. Why should not we stop erythromycin in this patient? This patient was doing well with those medications for quite a long time. And everything changed all of a sudden after starting this patient on erythromycin. Why should we not stop erythromycin?
I think the way the question is worded, they ask you the way the question is worded is like, what's the next thing that you do? You could stop the erythromycin, but like more currently they're already ditch toxic, so you wouldn't want to give them further.
No, it was not the most appropriate. Most appropriate step.
You can stop the erythromycin, but if you keep giving them digoxin and they're still ditch toxic, that would also.
No, but you'd say you should take, evaluating the medication and fixing the urgent problem. Remember these things, these questions, or when you go for your board exam, they are kind of tricky wording. You have to be aware of these things.
They're calling the urgent problem hyperkalemia or the ditch toxicity.
That's one thing. There is one thing. I will tell you the next thing. That's a good question. See, this is here. As a matter of fact, whenever you have ditch toxicity and you have a little bit hyperkalemia, you should not kind of superfix, hyperkalemia. A little bit elevation of hyperkalemia, if it is not dangerous, to the heart is good. You see here? If you are increasing, basically what? Ditch is blocking what? Potassium. If your potassium is a little bit on the higher side, this can contract the effect of ditch. If you are giving here calcium, you are basically doing what ditch is doing to your system. You got it? I mean, I understand your point, but one thing, we said after taking care of everything. After care of everything, you are using whatever you used, Digibind or whatever, patient is stable now, but it is the time to send the patient back to the nursing home. What do? You send patient on erythromycin? No. I said the most, appropriate. Probably that's right. You can say, hey, stop this one. But this is, I think that's because erythromycin caused problem. That's the reason we decide to stop that. And there is another thing. There is some studies basically. When you stop ditch, of course, ditch has no effect on the, doesn't help with prolongation of life or this type of thing. But if you stop ditch, there are studies that shows deterioration of renal heart function basically. Okay, Mr. Distinct white female who presented to the ER with complaint of progressive shortness of breath. She has history of CHF, CAD, hypertension. Basically, he had some back pain. She had some back pain, and she started taking some over-the-counter ibuprofen, which helped basically her back pain, but it caused the exacerbation of CHF. These are the medications. This is the EKG. Okay, what is the most likely cause of this patient's current problem? Okay, you can go clicking. Okay, that looks good. Okay, you see here, this is your one of the nephrons basically. This is the side effect of prostaglandins. By giving ibuprofen, you block formation of this prostaglandin. Prostaglandin keep these things patent and dilated. If you block it, it will be constricted. This one, where AC inhibitors acts, keeps it dilated. If this is constricted and that's dilated, there will be less filtration here. So this junks, so whatever fluid or salts or whatever you get into your proximal part of your nephrons basically get absorbed again, and there will be less salt and fluid in this area. So juxtaglomerular apparatus sensitive dehydration, and they cause release of a lot of renin. Renin basically cause what? You know the pathway, how it works basically, adrenaline and other, this one causes retention of more sodium in the distal part of the nephrons. Okay, I just want to go through Beer's criteria. Beer criteria has got updated recently. This is basically from the older version, but it serves the same purpose. These medications are know or be careful, okay? Muscle relaxant, sedatives, antidepressants, antihistamines, antihypertensive medication, spasmolytic medications, analgesics, and others. This is basically a kind of concise version of Beer's criteria. These medications should be avoided in elderly patients. And also, this is also from, that was drug body or drug body interaction, and this was a drug disease interaction basically. This is also from Beer's criteria. In case of CHF, you have to avoid these medications. Norpace, this is antiarrhythmic medication. NSAIDs, a sodium-containing medication, and some medication, basically rosiglitazone and other thing. And again, in case of peptic ulcer disease, you have to avoid NSAIDs, aspirin greater than 325 milligram. In case of COPD, long-acting benzodiazepines are not good. In case of diabetes, long-acting sulfonylurea, again, not good. In case of hypertension, pseudoephedrine, diet pills, amphetamines, they are not good. Cognitive impairment, barbiturates, anticholinergic, antispasmodic, muscle relaxant, and stimulators. These things are dextromethorphan, which is used for cough, methamphetamine, it improves, it's kind of stimulant, and methylphenidate, one medication which is used basically for attention deficit disorder. Incontinence, of course, anticholinergics. Parkinson's disease, dopamine, fall, benzodiazepines, tricyclic antidepressant, and chronic constipation, calcium channel blockers, anticholinergic, tricyclic antidepressant. Okay, this is some take-home points. Know your patients, obtain information by medical history of about social environment, support and function. Examine the patient and order relevant labs and other workup. Know the drug you prescribe, and know the drug patient is on. No drug is safe drug. Start low and go slow. Use your palm, PDA, whatever you have. Look for the mechanism of action. Look for the side effect. Look for the interactions. And communication is very important. That's basically part of transitional care. If we take a patient from a nursing home, we have to communicate to them. If we are sending a patient to the floor, we have to communicate to the doctor who is taking care of him or her when he or she is on the floor, or primary care physician when patient is sending back to the community. That's it. If you have any question, thank you. Thanks.